Hello, everyone, and thank you for joining us for today's webinar, Cystatin C and Race-Free GFR Estimation, Evaluating both clinical guidelines and laboratory perspectives on more widespread implementation, sponsored by Siemens Healthineers. I am Kaylee Bach of LabRoots, and I'll be your moderator for today's session. We have two key experts speaking today on different aspects of Cystatin C in evaluating glomerular filtration rates of the kidneys. I hope you will also find the content to be informative, interesting, and useful. Now, before we start, a few items that I would like to bring to your attention. Any questions or thoughts you might have can be submitted during the presentation into the Q&A box found on the bottom left-hand side of your screen. We will try our best to address those questions and comments during the Q&A portion of the webinar as time permits. In the event we're unable to address your question or comment during the Q&A, we will be sure to follow up promptly by email after the webinar. If you have any questions or experience any technical challenges related to the platform, please utilize the Q&A box to submit your request and someone will be able to assist you. Recently, use of algorithms that alter patient medical care based on race has fallen under increasing criticism as race-based medicine has been shown to contribute to healthcare disparities. In response to the National Kidney Foundation and American Society of Nephrology formed the Task Force on reassessing the inclusion of race in diagnosing kidney diseases. One of the preliminary recommendations of the final report, published September of 2021, was to facilitate increased routine and timely use of Cystatin C. As eGFR based on Cystatin C alone has never relied on a race parameter to estimate GFR. Given recommendations by Task Force to increase use of Cystatin C, two key perspectives are discussed. The first, current state of Cystatin C assay performance and standardization, as well as barriers and potential strategies to aid in more widespread implementation of Cystatin C testing in clinical laboratories. And second, describe the origins and consequences of race-based estimated glomerular filtration. Our learning objectives for today are to understand the importance of accurate GFR estimates in evaluating patient kidney function, describe the origins and consequences of race-based estimated glomerular filtration, discuss Cystatin C's role in NKF-ASN Task Force guidelines recommending race-free GFR estimation, and lastly, to identify strategies and expand implementation of Cystatin C testing in clinical labs for eGFR. With that, I'd like to welcome our first speaker, Dr. Amy Karger, Director of the Central Laboratory for the CKD-EPI Research Group since 2015, and therefore has expertise on the measurement of filtration markers, including creatinine, Cystatin C, beta-2 microglobulin, and beta-trace protein. Dr. Karger is a recognized leader in the field of laboratory medicine, currently serving in leadership roles with both the College of American Pathologists and the American Association of Clinical Chemistry, and is the Vice President and Chair of the Credentials Committee for the American Board of Clinical Chemistry. Dr. Karger has extensive experience directing or co-directing central laboratory testing for large clinical trials and multi-institutional research studies, including the Preventing Early Renal Loss in Diabetes study and the Epidemiology of Diabetes Interventions and Complications study. Dr. Karger, you may now begin your presentation.
Thank you so much for this opportunity to speak today and for that very kind introduction. So today I'm going to discuss Cystatin C and race-free GFR estimation and provide a clinical laboratory perspective on implementing more widespread use of this biomarker. And before I dive into my talk, I did want to share my disclosures. I have research support, or has had research support from Siemens Healthcare Diagnostics and Kiowa Kirin Pharmaceutical Development. I've served as an external consultant for Roche Diagnostics, and I've received speaker honoraria from Siemens Healthcare Diagnostics, the National Kidney Foundation, and the American Kidney Fund. And then lastly, I serve as director of the Central Laboratory for the CKD-EPI Research Group, and will be presenting some data from that research group today. So my learning objectives are shown here. Today I will describe the origins and consequences of race-based estimated GFR reporting, discuss Cystatin C's role in race-free GFR estimation based on the new NKS-ASN Task Force guidelines, describe the current state of Cystatin C assay performance and standardization, and then close by identifying the barriers to widespread Cystatin C testing and the strategies to overcome these barriers. I want to start briefly with some history on the origins of estimating kidney function based on race, as that will provide the background for understanding how we got to where we are today with GFR estimating equations. The primary means to assess kidney function is to determine the glomerular filtration rate, or GFR. GFR is a measure of how well the kidneys are filtering the blood, which removes waste products and extra fluid to produce urine. Studies have demonstrated that the GFR correlates well with other functions of the kidney and therefore is the best means for assessing the overall health of the kidney. GFR can be either directly measured or it can be estimated. Direct measurement is performed by measuring the plasma or urinary clearance of an exogenous filtration marker that's injected into the patient. Ideally, this exogenous filtration marker would be filtered by the glomerulus into the tubules and not secreted or reabsorbed by the tubules, so that the amount found in the urine reflects the rate of glomerular filtration only. Now, while direct measurement of GFR is considered the gold standard, it is an expensive and time-intensive procedure and therefore is not commonly done. Instead, estimation of the GFR is what is routinely done for clinical care. GFR estimation is based on calculations which incorporate measurement of endogenous filtration markers, namely creatinine or Cystatin C, along with demographic parameters to estimate the GFR. In regards to GFR estimation, I want to review the history of the equations and specifically describe when and why a race parameter was incorporated into these equations. Race was first incorporated into GFR equations in 1999 with the development of the modification of diet and renal disease, or MDRD, creatinine-based equation. The MDRD equation was the first eGFR equation that was widely reported by clinical laboratories alongside the creatinine result. The MDRD equation was the first to include a correction factor for African American race. In 2009, the Chronic Kidney Disease Epidemiology Collaboration, or CKD-EPI research group, developed an updated creatinine-based equation called the CKD-EPI equation. This equation was determined to be more accurate than the MDRD equation, particularly for individuals with eGFR greater than or equal to 60. The CKD-EPI creatinine equation retained a race correction factor for African Americans. Then lastly, in 2012, the CKD-EPI group published two new equations that incorporated the use of a new biomarker, Cystatin C. One of the equations was called the CKD-EPI Cystatin C equation, and the other was the combined CKD-EPI creatinine Cystatin C equation. The equation based on Cystatin C alone did not include a race correction factor, as Cystatin C had not been observed to vary among race groups. On the other hand, the combined creatinine Cystatin C equation did retain a race correction factor because that equation utilized creatinine, which had been observed to vary by race. So ultimately, why was a race correction factor initially incorporated into these equations? At the time of the MDRD equation development, recruitment of a racially diverse cohort into the MDRD study was viewed as an advance in racial equity and inclusion, as many research studies had predominantly white cohorts. Incorporation of a race coefficient was additionally viewed as an attempt to improve and tailor medical care to African Americans based on the observed differences in creatinine levels between the white and black cohorts in the MDRD study. This race correction was justified at the time by a hypothesis that African American individuals release more creatinine into the blood due to a higher muscle mass on average than their non-Hispanic white counterparts. However, data supporting that hypothesis at the time was limited, and in fact, many years later, in 2008, Stu et al. Rigorously examined this hypothesis and found no evidence that muscle mass or nutritional status explained differences in serum creatinine concentrations between African American and non-African American individuals. Additionally, since then, genetic studies have confirmed that race is not a biological construct, but rather is a social and subjective construct, and therefore should not be used to alter medical care for patients. So what impact has the race correction factor had? Many studies have reported on the disparities in care for African American kidney disease patients. Specifically, African Americans have declines in GFR at an earlier age and at a faster annualized rate than non-Hispanic white Americans. And they also develop advanced kidney disease at younger ages, with an incidence of end-stage kidney disease approximately 3 times higher than non-Hispanic white counterparts. Despite this, they are more likely to receive a late referral to nephrology and less likely to be treated with home dialysis therapies. They are also less likely to be waitlisted for kidney transplant and are transplanted at lower rates than their non-Hispanic white counterparts. These disparities are compounded by the use of a race correction factor to estimate GFR, which increases the estimated GFR for African American patients for a given creatinine level. So the equations make the African American patient's eGFR appear better than their non-African American counterparts. These concerns about the impact of race correction in contributing to healthcare disparities is what led to the development of new guidelines recommending race-free GFR estimation. I will briefly review the process undertaken to develop these new guidelines and then highlight the role of Cystatin C in these new recommendations. Over the last few years, there have been increasing calls to remove race from GFR estimating equations due to the issues I previously highlighted, disparities in care and the fact that race is not biological. Many attribute the beginnings of this effort to medical students who openly questioned the practice of race adjustments during medical school lectures and began to call for the removal of race from eGFR equations. In 2019, this issue was prominently highlighted in 2 major peer-reviewed journals, JAMA and the Clinical Journal of the American Society of Nephrology, who each published editorials criticizing the use of race in kidney function estimation. By early 2020, several prominent academic institutions then announced that they were no longer reporting race-based eGFR. This was then followed in May of 2020 by the murder of George Floyd, which brought forth heightened cries to enact broader and more meaningful change to race-based medicine practices in general to address healthcare disparities. So therefore, due to the national spotlight on racial inequities and the harm caused by race-based clinical algorithms, the nephrology community took action. The National Kidney Foundation and the American Society of Nephrology ended up partnering together to announce the formation of a task force in July of 2020 to critically examine the use of race in GFR estimation. They set forth to examine every aspect of the inclusion of race in these calculations, recognizing that changes in reporting must consider multiple social and clinical implications. They resolved to make recommendations based on rigorous science and be transparent to the public, clinicians, laboratorians, and other public health officials in regards to potential long-term implications of their recommendations. At the same time, in July of 2020, the CKD-EPI research group, led by Drs. Andy Levy and Leslie Inker, set forth to reevaluate the existing CKD-EPI creatinine-based equations with the purpose of establishing new equations without a race parameter. The pooled cohort data used to initially derive the original creatinine-based CKD-EPI equations were reanalyzed, with Black and non-Black participants now grouped into a single cohort to derive a single equation, rather than separating them into individual cohorts with separate equations. The new race-free equations were then validated using a new data set that combined cohort data from both old and new research studies. After 10 months of meetings and deliberations, the NKF-ASN task force determined the best approach moving forward was derivation of a single GFR estimating equation without a race parameter, derived from a racially diverse cohort to be used for all patients. The task force was aware of the parallel work by the CKD-EPI research group to derive such an equation. And in fact, Dr. Leslie Inker was on both the NKF-ASN task force and as part of the CKD-EPI research group. Therefore, CKD-EPI expedited their analyses and publication of their new 2021 equations, such that the task force final report could directly recommend immediate implementation of their new race-free equations. Both documents were then published online on September 23rd, 2021. The final task force recommendations are outlined here. The first recommendation was to immediately implement the new 2021 CKD-EPI creatinine equation that did not have a race correction factor. The rationale for use of this equation is that it does not include race, it includes diversity in its development, and is immediately available to all clinical labs since creatinine is a widely used assay. Additionally, the equation was shown to have acceptable performance characteristics. The second recommendation will be the focus of the remainder of my talk. The task force recommended national efforts to facilitate increased, routine, and timely use of Cystatin C, especially to confirm eGFR based on creatinine alone. The rationale: Cystatin C does not have observed differences between race groups, and therefore the original 2012 Cystatin C-based CKD-EPI equation never had a race correction factor. Additionally, studies have demonstrated that reliance on both creatinine and Cystatin C using the combined equation provides the most accurate estimate of eGFR. And then lastly, the task force third recommendation asked for more research on new biomarkers for GFR estimation, and also more research on interventions to eliminate race and ethnic disparities. So if we are to increase use of Cystatin C testing, it's important to understand the current state of Cystatin C assays and discuss how best to implement more widespread testing. First, I will focus on the assays themselves. An important issue to consider is Cystatin C assay standardization, as you would want results between laboratories to agree if all labs are using a standard equation to estimate GFR. Standardization is achieved through establishing traceability of methods to reference procedures or reference materials. There is a certified reference material for Cystatin C that has been available since 2010. And this allows assay manufacturers to calibrate their methods with the same reference material to facilitate the process of assay harmonization and standardization. Currently, all major FDA-approved Cystatin C manufacturers now have methods traceable to the reference material. The last manufacturer established FDA-approved traceability in 2018. So that has helped improve between-method agreement for Cystatin C, and I'll be showing data regarding this in the next slide. However, there is no certified reference method for Cystatin C yet. Therefore, establishment of a reference method should be prioritized to more robustly establish assay standardization. The improvement in Cystatin C assay performance over time is demonstrated in this figure. These data are comparing results from proficiency testing performed by CAP-accredited laboratories. These laboratories tested a serum pool collected from patients with known chronic kidney disease, shown in the left panel, and they tested a serum pool collected from healthy non-CKD donors. These two pools were tested in 2014, and then they created two new pools in 2019 and repeated the testing. As you can see in the left panel for the CKD serum pool, in 2014, the four primary Cystatin C methods had quite a bit of variability between methods, and the accuracy was mixed, with some methods within 5% of the target value and others more than 20% off from the target. There was a significant improvement in accuracy and between-method agreement in 2019, as shown on the right side of this first panel, with no method off by more than 10% from the target in 2019, and all methods in closer agreement with one another. The same patterns are seen with the healthy non-CKD serum pool shown in the right-sided panel, with an overall improvement in between-method agreement and accuracy from 2014 to 2019. So in summary, Cystatin C assay performance has significantly improved, and methods have an acceptable degree of accuracy and agreement to support use for GFR estimation. So the next question becomes, how do we support more widespread implementation of?
Well, thank you, Dr. Karger, for your informative presentation. I'd now like to introduce our next speaker, Dr. Alison Potok. Dr. Potok is currently funded by an NIH Career Development K23 award. Dr. Potok was awarded the prestigious American Kidney Fund Clinical Scientist in Nephrology Research Grant in 2019 through 2021. Her research focuses on understanding the reasons why serum creatinine and cystatin C may provide different estimates of kidney function within the same individual. She is also interested in tools used to predict the progression of chronic kidney disease. Dr. Potok, you may now begin your presentation.
Hi, thank you for this kind presentation, and thank you for having me. So I will be talking about the clinical use of Cystatin C. I have no disclosures. So the learning objectives will be to understand what factors influence creatinine and Cystatin C serum levels, to understand why it is important to accurately estimate kidney function and who should get Cystatin C measured, and to understand how to interpret or try an approach on how to interpret when Cystatin C GFR and creatinine GFR give different results in the same individual. So as Dr. Karger mentioned, the gold standard to estimate or to actually know somebody's kidney function is to measure it, but this is really difficult to do in clinical practice, especially in patients who are hospitalized and are acutely sick and need medications, since the measured GFR entails an infusion of a substance such as inulin or iohexol and measurements of blood levels to determine the clearance. So we use endogenous markers such as creatinine that has been used for decades. But creatinine is not a perfect marker. It's influenced by many factors independent of kidney function, such as diet, gender, age, muscle mass. So here is where Cystatin C comes into play, and we've been using Cystatin C for a few years now, but Cystatin C is also not a perfect marker, and it's influenced by different factors such as thyroid function, inflammation, certain drugs such as steroids, obesity, cancer, and so neither marker is perfect, but they both provide some estimation of GFR. So why do we need to accurately estimate GFR? One reason is medication dosing, because most drugs or a lot of medications are eliminated by the kidneys. This is a review that was done at the Mayo Clinic on the prediction of renal elimination of drugs with Cystatin C versus creatinine. So this review looked at 28 articles evaluating 16 different medications in 3,455 participants. Some medications came back multiple times, such as vancomycin, which is an antibiotic, very often used in hospitalized patients, in which we can measure the level in the serum, giving indication on its clearance. And so overall, this review showed that EGFR cystatin was more predictive of drug levels and drug clearance than EGFR creatinine. And so we need to accurately be able to estimate GFR for a lot of medications, since a majority of medications are cleared by the kidneys, eliminated by the kidneys. And this includes antibiotics, chemotherapy, where we want to make sure that we are efficient with the dose that we're giving, but also not toxic. And there's a new class of drugs, SGLT2 inhibitors, that have been shown to slow down progression of kidney disease, and we cannot give that to any patient. It kind of depends on the GFR, so it's really important to accurately be able to estimate GFR. Another reason to accurately estimate GFR is for diagnosis and prognosis purposes. So this is the KDIGO guidelines heat map. So the kidney disease improving global outcomes guidelines are followed by American nephrologists. And you can see here the classification of chronic kidney disease based on GFR and albuminuria. And so there are 5 classes, class 5 being close to needing dialysis, close to kidney failure. And so estimating GFR allows us to know in which class of CKD the patient is. And also in the to be able to give a prognostic, this is the kidney failure risk equation, and the QR code here will take you to the website. The kidney failure risk equation was created by Dr. Tangri a little more than a decade ago, and it includes age, gender, GFR, and albuminuria. You can actually access it yourself on this website, and if you plug in those 4 criteria, it gives you an estimation of your risk of end-stage kidney disease in 2 years and 5 years. And so knowing precisely what the GFR is allows to have a better estimation of this risk. who should we screen for kidney disease and how to screen? These are recommendations from experts at the KDIGO Controversies Conference, and their conclusion was that we should screen people with risk factors for kidney disease, including hypertension, diabetes, cardiovascular disease. The way to screen is using both estimated GFR and albuminuria. And as far as the estimated GFR goes, we should check both creatinine and cystatin to have the best possible assessment of GFR. I just wanted to mention here that we also check imaging when screening for kidney disease. This is a CAT scan of somebody who has polycystic kidney disease. You can see here on both sides the kidneys are really big with a lot of cysts, and that needs imaging to be diagnosed. You could have slightly decreased GFR at the time of diagnosis and some hematuria, some other, and a family history, but you wouldn't be able to diagnose without imaging. So what do we do if the markers don't agree? Now that we have two different markers, we can calculate two different GFRs, and if they're different in the same individual, then how do we know which one is more accurate? Well, it kind of depends. It depends what the person looks like. I don't pretend that I know anything about these two persons' kidney function. But on the right-hand side, you have Mr. Arnold Schwarzenegger, who is young and fit and has a pretty high muscle mass. And I would expect in someone with such a high muscle mass to have a high serum creatinine. But if we check a cystatin C, perhaps the GFR would look higher than the one by creatinine. On the other side, you have Mrs. Jeanne Calment, who is a French lady who is celebrating here her birthday. She's 121 years old, and she looks a little bit frail, and I expect her muscle mass to be low. And so if you were to check creatinine level in a frail old lady, you could expect the creatinine to be low, not necessarily because her kidney function is great, but because she doesn't have much muscle mass. And so if you check a cystatin C, then perhaps you would have a more accurate estimation of her kidney function. This is actually the focus of my research. I've been looking at the difference in eGFR by cystatin, by creatinine in various cohorts. And we constructed this difference so that higher is better, in the sense that we would expect this difference to be higher in people who are more fit and younger and healthier, and this difference to be low in people who are frail and with low muscle mass. And so this is the distribution of this difference. So if the two markers are in agreement, the difference will be close to zero. If GFR cystatin is very close to GFR creatinine, then the difference will be close to zero, which is in the center of this graph. And so we've been looking at this in various cohorts. This is an example of one of the cohorts where we kind of artificially decided that if the two GFRs are within 15 points of each other, we would consider that they're in agreement. And if they're more than 15 points different, then they would be different. So you can see here in the middle are those who have eGFR cystatin and eGFR creatinine that are within 15 points of each other. The green zone are those where the GFR cystatin is higher than the GFR creatinine by 15 points or more. And the red zone are those in whom the GFR cystatin is lower than the GFR creatinine by 15 points or more. So we would expect kind of people having a higher muscle mass and being healthier to be in the green zone, and those who are more frail and less healthy to be in the red zone. And we actually showed that those in the red zone are at higher risk for frailty. And at higher risk for hospitalizations, falls, cardiovascular disease, and mortality. So poor outcomes were associated with having a GFR cystatin being lower than GFR creatinine by 15 points or more. So then we asked ourselves if muscle mass could explain this relationship between the difference eGFR cystatin minus eGFR creatinine and frailty. Is it all explained by muscle? And so we looked at this in the health, aging, body composition study, where we had measures of muscle mass on imaging on both CT scan and DEXA scan. And we looked at the relationship between this difference in eGFR and frailty, and we accounted for several measures of muscle imaging, and so muscle mass on imaging, which is muscle quantity, and also we adjusted for muscle quality using grip strength and some measures of physical activity. And it doesn't explain it all. So the relationship was attenuated, but it didn't completely go away, which tells us that muscle explains part of it, but it doesn't explain the entire relationship. So I wanted to go over a few clinical scenarios where the GFRs may not always be in agreement, to try and see how to approach it. So this is our first clinical scenario. We have a 56-year-old Caucasian male with a history of hypertension and type 2 diabetes for the past 10 years. And he weighs 83 kilograms. And his labs show a serum creatinine level of 1.48 and a serum cystatin C of 1.40. The question is, does this person have kidney disease, and do we need to do any workup? So we're going to calculate the GFRs to be able to answer this question. So the eGFR using creatinine with the old equation was 52, with the new equation was 55. This person is Caucasian, so the new equation without race, the 2021 CKD-EPI, show a eGFR by creatinine slightly higher. And then the eGFR by cystatin C was 51, so pretty much in agreement within 4 points of each other. So looking at the heat map, if this was a chronic condition, meaning if his serum creatinine and cystatin C had been stable for 3 months or more, we could think that this patient has chronic kidney disease, and that would be stage 3A. And so both GFR, creatinine, and cystatin are agreeing on that. So he should probably get some workup for that, check the protein in the urine to kind of quantify if he has any proteinuria, and also I would check an A1C to assess how well controlled is his diabetes. Second case is a 70-year-old Caucasian female with hypertension who weighs 41 kilograms. So kind of a tiny person, and her serum creatinine is 0.4 and her serum cystatin C is 1.5. So here is a scenario where if you look at the serum creatinine, you can guess that the GFR is probably going to be quite high. And indeed, if we calculate the GFR, here's what we get. The GFR by creatinine, whether we use the old or the new equation, is more than 100 milliliters per minute. But if we check the cystatin GFR, it's actually 41. So looking at the heat map here from the KDIGO guidelines, her GFR creatinine is quite good, so she wouldn't qualify to have kidney disease based on that. But if we look at the cystatin GFR, she would have CKD stage 3B, assuming this is steady state and it's been chronic. So I would say that she most likely has kidney disease and that her serum creatinine is probably low because she's a tiny old lady and probably doesn't have much muscle mass. And so she needs further workup with checking urine for protein and checking renal imaging. Our third case is a 44-year-old African-American male personal trainer who weighs 95 kilograms. His serum creatinine is 1.55 and his serum cystatin C is 0.95. Does he have kidney disease and do we need to do workup? So if we calculate the GFRs, we get 62 for creatinine GFR based on the old equation, 56 based on the new equation. He's African American, so the new equation gets his GFR a little bit lower than the old equation with the race factor. And looking at cystatin GFR, he's actually at 89. So we often see referrals for patients who have high muscle mass and are pretty young and healthy and come to see us because their serum creatinine is on the high side, and if we check a cystatin C, the GFR is actually better. So in his case, should we do any further workup? I would say yes, just to cover our bases. I would probably still look at his urine and look at his kidney imaging. But I'm not really concerned. Case 4 is a 56-year-old Caucasian woman with hypertension and depression who presented with osteomyelitis of her left thumb, treated with IV vancomycin and Zosyn, and who was admitted with acute kidney injury. Her serum creatinine went from 1.0 to 11.15 within 3 weeks. So her GFR with a creatinine of 11 is only 6 milliliters per minute. The serum cystatin C is checked and it's 1.98, leading to an eGFR cystatin of 32, so quite better. And since she got vancomycin, we have the advantage of being able to check a level, which also helps estimating the kidney function, as it gives an indication on clearance. And so the vancomycin random level is 120. So this patient ended up having a kidney biopsy. This is a real case, and she had vancomycin-associated CAS nephropathy. So the pathophysiology of vancomycin-associated CAS nephropathy is still not fully understood. There's a couple possible pathways. Either the acute kidney injury comes first from proximal tubular injury, and this leads to reduced urine flow and CAS formation, or maybe the CAS formation starts first from the increased vancomycin concentration, which leads to obstruction of the tubules, which leads to the acute kidney injury. So in this case, I think it's more likely that the second hypothesis is the right one. I think it would explain why the creatinine and the cystatin C are so widely different. The obstruction probably blocks the creatinine excretion, leading to a high serum creatinine level. But the cystatin C is reabsorbed and metabolized by the proximal tubules, and this can still happen, which explains why the cystatin C level is lower. And the GFR appears better when really the vancomycin random level of 120 tells us that the kidney function is very close to 0. So there are a few scenarios where this happens with the serum creatinine being much higher than the cystatin C. And this includes urinary obstruction and rhabdomyolysis as well. I hope these clinical scenarios were helpful to try and guide the clinician as to how to approach a problem where there's two widely different eGFRs in the same person. I think it's really helpful to check cystatin C, even if it's only to confirm the creatinine-based GFR. At least it kind of comforts the clinician that this is probably close to the true kidney function if both estimates are in agreement. Neither the creatinine nor the cystatin C are perfect markers of kidney function, as we mentioned. I think there is really important clinical information embedded in this difference in eGFR by cystatin C and creatinine, and I purposefully left out the combined equation that includes creatinine and cystatin C because I think it just pretty much provides an average of the two separate eGFRs, but I think there's information that is lost if we just look at the average of the two. And there's actually really important information when we look at the two separately when they're widely different. And finally, having an eGFR creatinine higher than the GFR cystatin is associated with poor outcomes, frailty, hospitalizations, mortality. Thank you. I'm happy to take any questions.
Thank you, Dr. Potok, for your informative presentation. Now, before we start our live Q&A portion of the webinar, I want to pass the mic back over to Dr. Karger. It seemed as though there was a bit of a technical difficulty that cut off the last few slides of her presentation here. So, Dr. Karger, I want to pass it over to you to provide that final summary here.
Yes, thanks so much. So I can just summarize what was at the end of my talk since that was missing for those who are watching this live. So in the last part of my presentation, I was talking about some of the barriers to cystatin C testing. The main ones are the lack of widespread availability of tests in-house for cystatin C. Most clinical laboratories send out for cystatin C testing, which obviously will slow down your turnaround times, and not make that a result available at the same time as a creatinine-based eGFR. Other barriers include cost. Cystatin C remains significantly more expensive than creatinine assays. And then the other issue is the availability on instrumentation. So creatinine is available on all sorts of platforms, big and small. Cystatin C is just not as widely available as creatinine, although there are manufacturers who have moved cystatin C onto more commonly used chemistry instruments. There's still a lot of manufacturers who don't have their own cystatin C assay and are relying on open channel cystatin C assays rather than developing their own. And so I think we need to have more manufacturers develop their own cystatin C assays for their instruments. And so a couple strategies for implementing cystatin C. I think number one, it's important to have clearer guidance on clinical use, and that's something that's continues to develop. For example, the KDIGO guidelines have not been updated to match the new NKF-ASN task force guidelines, so I think those need to be updated because those are now not in sync with what the NKF-ASN task force has said in terms of increasing use of cystatin C. I think we also need to prioritize placement of Cystatin C on more platforms like creatinine if we want to see it used more widely. And then I think a really important step that can be taken by nephrologists is to engage their clinical laboratory directors and try to get testing in-house in more locations, and also for nephrologists to provide education to providers if that testing is brought in-house as to how to use Cystatin C. And then lastly, if we can get better reimbursement and lower costs for the Cystatin C assay, I think that will also aid in implementation.
Great. Well, thank you, Dr. Karger, for reiterating that and summarizing those last few slides there. Now, to our audience, I'd like to welcome everyone to participate in our live Q&A session. So as a reminder, if you have a question that you'd like to ask, please do so now. Just click on the Ask a Question box located on the far left of your screen, and we'll answer as many of your questions as we have time for. So let's get started. Our first question is for you, Dr. Karger. This question says, you mentioned that Cystatin C is traditionally performed on immunoassay instruments, but more recently that manufacturers have made versions available on clinical chemistry instruments. Could you please discuss some of the differences running Cystatin C on these different platforms?
Yeah, thanks so much for this question. So I alluded to this a minute ago that traditionally Cystatin C has been run in more specialized laboratories, but some manufacturers have put the assay on the clinical chemistry instruments that are in more laboratories and acute care laboratory settings and make the testing more widely available. In terms of the differences in running it in a specialized lab versus on a chemistry platform, comparisons between assays have shown that they agree pretty well now that manufacturers have harmonized assays to the reference material that I mentioned in my talk. And so the between method agreement is pretty good. There's always room for improvement. And I think if we can get a reference method, that would push us even further towards better harmonization. But basically, the main benefit of having it on those chemistry instruments is that it provides the opportunity for more labs to bring in Cystatin C, because those specialized immunoassay instruments are only going to be available at academic institutions or send out or reference laboratories. So that's the main benefit of it being on those different types of platforms is more availability.
Great, thank you. My next question here is for Dr. Potok, and this is a two-part question here. So this asks, any thoughts or guidance on how to make the transition from eGFR creatinine to eGFR cystatin less challenging for clinicians? And could you speak a little more to the rebaselining of patients?
Hi, yes. So I think it is going to be challenging for clinicians to move from one to the other. Like everything new, you need to get used to it and get comfortable with it. So I think the more we use Cystatin C, the more comfortable we'll be using it and trying to understand, in which settings it provides a different GFR from creatinine. I don't think that there is actually a rebaselining of patients, meaning, we've been using creatinine for a very long time, and we can usually follow the trend over time of what the creatinine level is. And we've been using, in some places, Cystatin C for a much shorter period of time. And so if you follow a patient and his creatinine level has been quite stable for several years, and it provides you a, given GFR, let's say, 40, and then you check Cystatin C and it provides a GFR of 25, it doesn't mean that this patient's kidney function dropped that day. It just means that now we have a new marker. Well, it provides you a different answer as to what the GFR is, and the question is which one should we trust? But I think it's reassuring if the creatinine level has been stable for several years, that we know the kidney function has been the same for at least that period of time. And just having this new marker, we maybe need to be a little bit more careful with dosing of medications and try to understand why
we get different values. But I don't think that it means this patient's kidney function changed, you know. I hope that answers the question.
Great, thank you. Our next question here is for Dr. Karger. This question asks, the NKF ASN Task Force guidelines recommended more widespread use of Cystatin C, but didn't provide a lot of details regarding how to incorporate it into clinical care. Do you recommend waiting for additional guidance from nephrology societies before we dive in?
That's a great question. I actually think we're underutilizing Cystatin C even based on outdated guidelines. So for example, in the 2012 KDIGO guidelines, they do say Cystatin C should be used to confirm EGFR when the creatinine-based estimate is in question, or if you're, at a cut point for diagnosing a patient, or, you're a border between different stages of CKD or between CKD or not CKD. Encourages Cystatin C as an alternative. And what we're seeing is really it's very underutilized even based on those old guidelines. I do anticipate that there is going to be more granular and clear guidance coming forth in the next couple of years based on the NKF-ASN Task Force recommendations to use this biomarker more. But I think it's fine to jump in and encourage providers to use it now. Educate providers on it. I think it's good to have maybe a slow ramp up and make them aware of this as an alternative, and especially for those patients who have factors that would affect the accuracy of creatinine-based estimation. For example, those on the extremes of muscle mass. You really shouldn't be using a creatinine-based estimate. You should really be looking at Cystatin C. So there's a lot of opportunities now to use it, and then we should just keep an eye on what those future guidelines are going to be, and we could always evolve our use based on the future guidance.
Great, thank you. All right, I have another question here, again for Dr. Potok. How do you think Cystatin C might affect referrals to nephrology?
I think it will probably increase referral to nephrology, and that's okay. I think, in my institution at the University of California, San Diego, and at the VA, we have been using Cystatin C for a few years now, and try to check it in our clinics and on the inpatient setting also. And it's not always easy to understand why we get different GFR values. So we actually have a little consult service among us nephrologists, and I get a lot of text or emails from my colleagues with questions on how to interpret and what to do. And I think the more we use it, and the more comfortable we'll be using it, and it's okay if we get more referrals for a while until people understand how to use Cystatin C and how to interpret the results.
Thank you. All right. Next question here. Do you recommend reporting EGFR based on Cystatin C alone, or EGFR based on both creatinine and Cystatin C in the combined equation, or both?
Yeah, that's a great question as to how to implement this and which equations to report. I think in the future, in an ideal situation, we would actually report a trio of estimates: a creatinine-based estimate, a Cystatin C alone-based estimate, and then the combined estimate. And why I think having all three is important, Dr. Potok alluded to this earlier. Having the individual creatinine and Cystatin C estimates allows you to see if there's a major discrepancy between the two. So you want that information to see and to really inform you as to whether maybe there's an issue affecting the patient's creatinine or Cystatin C that's not GFR related. So you can identify which of the two estimates is most accurate in terms of estimating their kidney function. But why should we report the combined equation? And this alludes to one of the questions that was asked also in terms of data comparing all the equations. Data has shown that the most accurate estimate is the one that relies on both biomarkers together, the Cystatin C plus creatinine equation. So if you have all three equations and they all are in relatively good agreement, then you could rely on that combined equation as the most accurate estimate. If, however, you see the three estimates and you see that the creatinine and cystatin C don't agree with each other, they're very discrepant, you shouldn't use the combined estimate because it's averaging the two. You should look at the two, creatinine alone and cystatin C alone, and really think about what about this patient could be affecting either the accuracy of the cystatin C or the accuracy of the creatinine. So for example, if they're a heavy smoker, we know smoking impacts cystatin C accuracy. So then you'd want to just rely on creatinine only and not the combined equation. So that's why all three equations can be useful for really figuring out what the kidney function of the patient is.
Wonderful. Well, thank you, Dr. Karger and Dr. Potok, again for your time today and your informative presentation. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speaker via the contact information you had provided at the time of registration. So we would also like to thank LabRoots and our sponsor, Siemens Healthineers, for underwriting today's educational webcast. And this webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.